Good afternoon, everyone. We are going to get started to hear from our panel of experts here. Before we do, I just want to say there is still plenty of food. The catering staff is going to leave it out for a little bit. If people want to go get seconds, feel free to kind of sneak away and get some or another drink. We also will have boxes for people to take home because we don't want anything to go to waste. Bridget Flood, the Executive Director of Incarnate Word Foundation, is going to moderate the panel, but I have the lovely privilege of introducing our guest panelists today. So first is Terry Plain. Terry serves as a Senior Strategist at Missouri Foundation for Health with over 20 years of knowledge in philanthropic grant-making, public health, and community collaboration. Terry leads multi-year initiatives focused on maternal and child health. She's a forward-thinking practitioner of diversity, equity, and inclusive-based strategies through which organizations can effectively inform, support, and empower the communities they serve. Terry is a graduate of Spelman College and Southern Illinois University at Carbondale. She volunteers with the Dutchtown South Community Corporation and local chapters of Spelman Alumna Association. She loves traveling, journaling, and jazz music. I love your bio. Next, we have Melinda Monroe. Melinda is the Chief Executive Officer of Nurses for Newborns, following the founder in 2008. She holds a degree in biology and psychology from Indiana University and a master's degree in clinical development psychology from the University of Illinois at Chicago, focusing on infancy.
Katie, can you hold that mic a little closer?
Melinda has served on national and Missouri state task forces on fetal alcohol syndrome, substance use in pregnancy, prematurity, and infant mortality. She currently chairs the region's Safe Sleep First project comprised of 18 agencies who are leading a campaign to end racial and economic disparities in infant safety during sleep. Melinda is a passionate speaker and advocate for prevention services, early intervention, and family resource development. Melinda is a mom to 2 adult sons, both born prematurely, and she can be found letting off steam as a singer, songwriter, and guitarist. Next, we have DiAnne Mueller. DiAnne is the Chief Executive Officer of St. Louis Crisis Nursery for more than 28 years, providing leadership, oversight, and supervision for 5 crisis nurseries, 9 outreach centers, and the regional administrative offices. DiAnne is a licensed professional counselor with a master's degree in counseling from Drake University. She possesses a unique blend of experience, which includes work as a correctional counselor, clinical consultant in the development of sexual abuse treatment programs, and psychotherapist and family therapist. Making an impact in the community, she currently serves as president of the St. Charles County Family Stress Council, is a member of the Domestic Violence Board in St. Charles, the American Association of Counseling and Development, the St. Louis Council on Child Abuse and Neglect, and the Human Services Community Advisory Board. She's also the past president of the St. Louis Council on Child Abuse and Neglect. Recognized as an expert in child abuse prevention practices, she's frequently consulted by corporate and legislative leaders for her position on issues concerning children and families. DiAnne and her husband are parents to 3 adult children and reside in St. Charles. Sorry, I'm losing my fingers here. Last but certainly not least, we have Dr. Anne Sebert Kuhlmann. Anne is a professor of public health at St. Louis University with over 20 years of research experience in maternal and reproductive health. She has worked both domestically and internationally in several countries in Latin America and sub-Saharan Africa. Recently, she has focused much of her research attention on issues of period poverty and menstrual hygiene needs here in St. Louis, across Missouri, and nationally. So we are very excited to have this esteemed group of experts with us. So I will turn it over to them.
Good afternoon. So I'd like to start with our first question, which is, could you give an overview from your perspective of the state of maternal child health in St. Louis, and also how does your work touch upon this? Terry?
Good afternoon, everyone. Thank you for letting us come out today to share different lenses of our work and our organization. So in thinking about the landscape of maternal child health in St. Louis, it's not looking too good, unfortunately. We can talk about the statistics. So Missouri, unfortunately, has the 7th highest maternal mortality rate in the country. These are areas where we don't want to be number one. We don't want to be in that position. Also, within Missouri and very reflective of St. Louis, Black infants and Black mothers are still dying at 2 to 3 times the rate that of their white counterparts. This is due to a variety of factors. It relates to access to care, but it also relates to a very understood, at least literature-wise, but how that is internalized, institutional racism, systemic racism that is pervaded through a variety of systems and a variety of levers that deal with healthcare, that deal with social determinants of health, the factors that really lay upon aspects of how we can engage in health. So that relates to transportation, it relates to food, it relates to housing, it relates to employment. So we at the foundation look at where these factors kind of go from in a larger landscape to really talk about the landscape. It's just not one sector. We try to engage in a variety of sectors that we believe are helping to build and helping to offer opportunities where we can make more systemic changes.
I think I'm good.
Oh, thanks.
Okay, does this work?
Yes.
Oh, I got lots of smiles. Thank you so much for inviting me and my esteemed panelists here this afternoon, and to be able to speak about a very difficult subject in many ways in such a beautiful space. I'm reminded of that paradox and lovely food, I might add, from the library. I really appreciate the meal as well. Thankful for that. So, not too long ago, we had a family that we were serving at Nurses for Newborns who was had a pretty normal pregnancy, referred to us in the first trimester, had a pretty normal pregnancy, and right after the baby was born, mom started having headaches and reported them in various places, sort of without a whole lot of urgency at first, saying, I wake up and I have a headache. And she talked to her mom, and she talked to some family members and some friends, and of course she was given a lot of different kinds of advice around what to do with headaches. Eventually she called her clinic, the clinic that she had been going to, and said, I'm having these headaches. And they told her that it was going to be something like 6-week wait to get in to see a physician, and if she needed to see somebody sooner, she would need to go to urgent care. So with a newborn and a toddler in the household, that was not something that she could really pull off at the moment. So a few days after that happened, it was time for her visit with our nurse at Nurses for Newborns, and the nurse took one look at her and said, what's going on? And she says, I just have a blinding headache, and I have this ache under my rib cage, and I can't hardly function. And she was actually laying on the couch when the nurse arrived. And so the nurse kind of skipped all the normal things we would do in the beginning of that visit and whipped out, what do you think she got out? Her blood pressure cuff. Exactly. And her blood pressure was 195 over 110. And she was 2 weeks postpartum at this point, so 2 weeks after delivery. So our nurse's next action was ambulance. Absolutely, 911. She ended up in the ICU with a central line in order to get enough blood pressure medicine into her to save her life. And she was literally, you know, the physician who gave feedback to our nurse about the incident said that, you know, she was within hours of losing her life. So what went wrong? What went wrong there? There are actually multiple points. And the reason I start with this story is that she didn't really have red flags, you know, that were waving anywhere during her pregnancy. People think about blood pressure during pregnancy. They don't always think about it afterwards. And there is actually a lot of evidence that some of the maternal mortality that we're seeing is around hypertensive events or hypertension after the baby's born, in especially those first 3 months. And it's not widely known. So there's problem number one, is education. That symptoms of hypertension after a baby is born are actually of concern. It's not a benign kind of situation. Second of all, this was a woman of color. She was not listened to. There were multiple points. I'm giving you the just highlights of the story, but there were multiple other points where she brought up her headaches and was not listened to. And we have tracked that back as a community to all sorts of things, but the highlight of which is racism. And until we address that particular issue of why we are not listening to Black women around their medical concerns, we aren't going to get anywhere with this issue. And when I say we, it's really we. It just so happened that we were involved with this family as nurses for newborns and was able to intervene, but honestly, that could have gone very, very poorly. So what does that say about the state of health for women in St. Louis, in our region, and for the babies as well? Because if you think about it, that 2-week-old is now in crisis. She was breastfeeding. So now we have a crisis with the newborn, which you're going to hear from DiAnne here next. We'll hand that off to her. But when we think about women, I wanted you to have a real scenario in your mind of how that can really deteriorate quickly and what it means to a family to be able to have the kinds of resources and services and mindset of the caregivers around her in order to make sure she gets the support that she needs around that pregnancy and that postpartum period. So on the flip side, I do think we have some positive things happening. They're emerging. There are some statewide efforts that are going on around both maternal mental health and maternal health that didn't used to exist. And I'm hopeful that we can make a dent in some of the issues that are going on. And we'll be talking more about that this afternoon through our questions. Hand it off to DiAnne.
Wonderful. Thank you. Thank you. Thank you very much. I too want to thank you all for being here. And I have to tell you that when Kate reached out to me to be here today, I didn't even look at my calendar. I just said yes, because history is so important to me. And I was sharing with my table that it was 15 years ago when we became aware that our community was really struggling with Latinx families moving here, and they needed more services. And we wanted to be able to help with that, and so I hired social workers to do that, and I didn't have any way to pay them. And I talked to Bridget at Incarnate Word, and she said yes. And I'll never forget that she was the first one to help us with that. So great history with Incarnate Word, being where you need to be and helping where you need to help. And as I was driving here today, I thought about that again. I thought, isn't this wonderful that you all care about these families, about these mothers, and about these children, and you want to know what's going on, and you want to know what we're going to do about it, right? Thank you. Bless you. Thank you. So I, too, want to start with a story, because you know the numbers. You can Google it, and you can read about all of those numbers that are just absolutely horrific in our community. But what you won't forget is when I tell you my story about Katie. This you will remember. And this is a situation where a young mother had a new baby, around 6 months old at this time. And this young mother, when she first got pregnant, guess what? Her family disowned her. Didn't want anything to do with her because she was a young mother. And Dad, who were trying to get these dads more involved with us and with the system, and took off for California when he learned that he was going to be a dad. So he's out of the picture. So she's alone. And on this particular day, little Katie was crying all day long, crying into the night. Got to be about 2 o'clock. Mom had tried everything, right? We know what to do, don't we? We walk, we feed them, we change their diaper, we do everything, walk them back and forth. Nothing's working, nothing at all. So then this mom remembers that she saw a TV commercial where something about putting a baby into bubble bath, and then that would calm her down. So she said, okay, 2 o'clock, I'm gonna try this. Made the warm bubble bath in the kitchen sink, actually, and put some bubbles in there and put the little baby, we'll put little Katie in there. Guess what? It didn't work. Katie kept crying. Mom's alone. She's at the end of her rope. She can't take it anymore. And she starts to think, I'm a bad mom.
Yep.
I can't do this. And I sure can't do it alone. And then we're really spiritual at the Crisis Nursery, and we believe that it was the grace of God that she had been at the laundromat a couple days ago, and she saw one of our flyers hanging up that said, parenting is hard, and call the Crisis Nursery when you need help. She had taken that phone number down. So at 2 o'clock in the morning, she called us. And we're 24 hours a day, 7 days a week. We never go home. We never close. She called the nursery. And in her mind, what she told us later is she decided if the phone rang and rang because we went home at 5 o'clock, Katie would die. She was going to drown her. If somebody answered, she would get some help. So we did answer and listened. We listen a lot to our families. We listen to their pain. We listen to their suffering. And then we problem solve. And so the solution here was we have a transportation fund. So we sent a cab for Mom and for Katie and brought them into the nursery. By then it was almost 3 o'clock in the morning. And sat and listened to Mom some more. And one of the staff took Katie across the street to St. Joseph Hospital and had her seen in the ER. And does anybody want to guess what was wrong with Katie? Why was she crying so much? What makes babies cry? Like teething, ear infection. That's exactly right. One of the worst cases of bilateral ear infection that this pediatrician had ever seen. But my question to you all is that a reason for a baby to end up dead? And we all know the answer is no. And what we also need to know is that because of places like the St. Louis Crisis Nursery, Katie's alive today. She still has her mom. They're still a family. And they're doing great. They have continued on in our program. And today, Mom actually has a wonderful job. Katie is in daycare. We've done home visits with them, and I'm just so proud. I am so proud of the literally thousands of families that have success and that are doing well, and that we wrap our arms around them and we keep these babies alive. And that is so very, very, very important. And so that's when, when the question is, how does our work touch upon this? Our work touches upon one family at a time, one child at a time. And whatever it is that that family needs, that's what we're gonna do. If it's 2, 3, 4 days of respite care, we call it respite. It's a safe haven. The infants get held all the time. That's kind of a rule, is they need a lot of hugs and a lot of love. And they need all the formula and the diapers, and all that needs to go home with them. As they get a little bit older, because our families do stay with us, when parents call, and sometimes it's because they've been evicted. The unhoused, we call them, homeless. That's a serious problem in St. Louis. Those are our kids that are sleeping in cars, sleeping on the neighbor's floor because they've been evicted, and those are the families that we work with. It's about a third of our families. 33% are coming to us because they have nowhere else to go, and there are no shelter beds in the city of St. Louis available to them. That's a whole other story. Invite me back to talk about homelessness. I have pretty strong feelings about that. So, and domestic violence also. I'm sure that you've read how the numbers have just skyrocketed during the pandemic. Those are our families. Moms who have been having to stay in bad situations because of the pandemic, and they can't get out, and the anxiety and the depression and the substance abuse, all of that. So do you know what we do? We go out, and today I'm dressed up for you, but so when I go out into the community, I wear my t-shirts and my blue jeans, and I take my social workers with me, and I take my students from St. Louis University, Washington University, and we go into the highest risk, highest poverty neighborhoods, and we knock on those doors. 63106, 63107, those are our neighborhoods. North St. Louis City. We know those families. We've had a family empowerment center in that community for 20 years. 20 years ago at St. Teresa's and Bridget's, we opened our family empowerment center, and we're not going anywhere. We're growing and expanding. Our Lady of Perpetual Help, we're there also. So that's my philosophy, is that if families don't know help's available, they're not gonna reach out. I think it's my job to go knock on those doors, meet those families, show them how kind and loving and friendly we are, and listen to what they need. And so many times, I cannot tell you how many times a parent has said to me, how did you know to come today? How did you know? It goes back to that spirituality thing, right? How did you know to come here today? How did you know to bring formula with you? Because I've been feeding my baby water. How did you know to bring diapers? Because I've been washing out disposable diapers for 3 days now. I call that the violence of poverty. When you are that poor and you cannot afford things, we as a community need to wrap our arms around those families. So that's what we're doing at the St. Louis Crisis Nursery. Thank you.
Thank you, and thank you all for the opportunity to be here today. So I'm a professor of public health at St. Louis University, and so my role and perspective is a little bit different, right? Because as researchers, we're not the ones, and as educators, we're not the ones who are doing the implementation of the direct response, but we are the ones who are doing the background research, the data collection to get the statistics and information out there for others to be able to use in those grant applications, to use in the funding, to use in the legislative advocacy. So really, from a faculty perspective, I see our roles in two very important components, and one is that data component, right? If we help collect and track and evaluate to be able to bring to the forefront of what are these issues. So what are the numbers and the extent and the magnitude. We need both the personal stories and the overarching, how many people, how big of an issue is this, and to, how wide, what areas, that type of thing. So that, and then I take our role as educators really to heart, right? So this semester I'm teaching an undergraduate introduction to public health class, and guess what this week is? It's maternal child health. And I have 68 undergrads from St. Louis University. Most of them are freshmen, and so they are 18, 19 years old. And so talking about these very statistics and sharing these very types of stories for those who are young adults in our society, right? For those folks to be aware of what are these issues right here in the same neighborhoods where they're going to school, and many of them will stay and work. And I feel like it's a privilege to be able to help influence or shape the worldview of so many young adults, and to make sure that they're aware of these issues and they're aware of the racial disparities and the inequity and how the structural racism has affected so many families and so many individuals. And so I think that those two components, while I don't do direct services or direct implementation, those two components are really important in how we can contribute from sort of that university faculty perspective. And since this is an area where I have done research a number of years, both in St. Louis and elsewhere, also I think something that's really important for us to focus on is thinking about the importance of the underlying health status of women in our communities, in our cities, right? Not just once they're pregnant, once that baby's come. Because so much of what happens or might happen during that pregnancy is already set by that underlying health status, right? Nutrition, high blood pressure, chronic stress. And so making sure that we are also doing things that really focus on and place value on the health status of women and girls in our society, I think is really important. So that so that we can hopefully see the benefit over time and sort of generationally, right? And from a reproductive health perspective, and where I have focused a lot of my attention in the last few years is around menstrual hygiene and period products and access to period products and those experiencing period poverty, and using the data to bring that issue to attention. Now, that is not direct maternal and infant health, right? But that feeds into, and some of the work that we have been doing most recently is with students in charter schools in the city of St. Louis, and we've worked in North County at Jennings High School as well, hearing from the students the questions that they have about their periods and menstrual hygiene is so insightful, because it makes you realize that there's a lot of lack of understanding of bodies and how they function and why they function and how we can care for them and personal hygiene. And all of that is going to carry forward, right? So the importance of laying that foundation in middle school and high school as all of them develop into young adults who are going to be those moms and those parents and stuff. And so, again, my perspective is a little different here. My role in the panel is a little different, but bringing that perspective of really thinking about what are we doing for the health and the status of women and girls overall in our community, so that one of the positive aspects that we will have is that impact on maternal health and infant health. And then what's the role of researchers and folks at universities from sort of that education and data perspective, and what kinds of data and information do people need and want to be able to do the legislative advocacy and to develop the programs and that sort of thing. So.
Thank you, Anne. I'm going to combine our other two questions. This is a very interesting topic. I know when I was preparing for this, I came across a statistic that said that in terms of the racial disparity, the outcomes for middle and upper middle class Black women are worse than the outcomes for low income white women, which really struck me. So it's not just poverty, the racial aspect, the discriminatory and racial prejudice that exists is also part of the whole problem, at the heart of the problem. So it's much bigger than poverty, it's also racism. So my next question is, what are things that you're doing to address this, and what can we do? What's the call to us to action? Terry, would you like to start?
Sure.
Can you use the other mic? Make all the difference.
Hello, is this better? Okay.
It's better.
Missouri Foundation for Health, we have been engaged in infant mortality reduction work for the past 10 years, and we're continuing to evolve that to engage kind of more statewide work and engaging in improving maternal health outcomes. But what has been done specifically, probably for St. Louis reference, is the work that we have partnered with for Generate Health. If you're familiar with Flourish, Flourish St. Louis, so for the past 10 years, Flourish is an initiative that has evolved through building and really empowering community leadership and governance. So a part of this work is not just about us helping or us supporting, but it's also about building the leadership capacity of community, because most certainly a founding, the foundation of this initiative that we have is understanding that community solutions are best served and best implemented by those most certainly impacted. So this is not a, we are the heroes. We most certainly are not. So Flourish really helped to develop a community leadership board, a community leadership board that helped to develop priorities in St. Louis, focused around a lot of the social determinants, safe sleep, mental health, behavioral supports, and other type of perinatal supports. Another part of the work was developing action committees that did focus on transportation, that focused on housing. So there was a true understanding of where there were levers related to infant health that needed to be recognized and elevated. Another part of that work was also recognizing and beginning to really beginning to disseminate the narrative of implicit bias and understanding the racism that occurs throughout all aspects of perinatal care. If you've engaged in any type of anti-racial training, you understand the aspects of implicit bias. You don't even know it's happening. And this is where, as community leaders and organizations we're truly understanding that this is a part of where they can contribute to solutions, that empowerment and that awareness is where they were able to truly begin to make change. Another piece of our work in understanding community-informed solutions was examining how we think about those solutions. And a part of that was us giving up our grant-making, quote-unquote, authority. So we actually developed community grant-making structures where Flourish made their own decisions on what type of community organizations, based on their community leadership priorities, would be able to then help to be a partner in engaging in infant mortality reduction work. And what that raised was the notion that it's not going to be the people and the organizations that we typically know. There are myriads of community organizations and coalitions that are in St. Louis that is doing this work, and to help to bring together kind of common ground elements of addressing infant mortality and inextricably maternal health, you began to see how these community organizations began to really understand, yes, we play a role in this. For example, how many are understanding the need for fatherhood programs? That is extremely vital in making those stronger connections to where we can address social determinants, where we can look at ways to change the narrative of what infant health and what maternal health looks like. It is not on the onus of the woman and birthing person to begin to engage and make those decisions. This is a family-oriented way of addressing overall health. Another part of that is understanding that recognize that Black providers need to be elevated and recognized. So what does that mean? Having more training programs, having more opportunities to engage in culturally congruent type of care that is recognized within communities of color. Being able to speak to what is the data, and I'm so glad you talked about, Dr. Kuhlmann, the aspect of kind of really looking at indicators and data. So we have kind of this traditional mindset of what data looks like, but we also need to recognize that with data, it may be received as information, but where can the idea of wisdom, there is an aspect of lived experience and knowledge that is important. But where can community lived experience and wisdom be elevated in this work? Because that has to be validated. I was just on a call last week with a group of funders. Nationwide, there's an emerging group called the Birth Equity Funders, and Kellogg Foundation is doing some work in New Mexico. So they were providing models of care that were rooted in indigenous peoples' traditions, understanding what a talking circle looks like, what does a healing circle look like. So these were areas where empowerment among stakeholders and among those most impacted is helping to lift what care should look like and what competent care should look like. So that's kind of, I know I'm continuing to talk, but that's where I want to speak to. This is what is happening, this is what can happen, and I'm going to pass it to you, but I want to just put in making sure that we understand that there is also a momentum and that we're continuing to support about coordinated care. I think Melinda talked about the mental health aspect, but connecting kind of that clinical care to making sure that there is additional support for mental health. And so I'm going to put a plug in for the Bloom Network, and then I'm going to hand it to you because then you can kind of share a little bit more about that. Thank you.
Thank you. So this is a multifactorial issue that we're talking about, and so the solutions are multifactorial. There are many, there isn't going to be one thing that we can wave a wand and solve the problems that we've described today. So it's going to take a little bit of this, a little bit of that, and a lot of this and a lot of that. And so I'm delighted that we have a crew here who's interested in this topic and can take on your own piece. And I think hopefully you'll leave with some ideas on how you can do that when we leave today. So at Nurses for Newborns, I can tell you a couple of things that are happening that immediately address the issues that we're talking about. And the first one is to reduce barriers to care. And when we talk to young families, or if you have a young family in your life who may not have economic resources or is enduring stress, including the stress that was just brought on to us by the pandemic, you know that they are facing barriers and hurdles that they have to jump that my generation did not have to jump. And so by bringing care to a family, we are a home visiting organization, so we provide home visits by nurses or community health workers in the family's home or through telehealth now, thanks to the pandemic, as an option. We're reducing the barrier to, I can't get to the doctor, or my baby hasn't seen a doctor yet and they're 3 months old. Or the mom that we talked about who couldn't get a doctor to see her with a health problem that turned out to be an emergency. And so by reducing those barriers, we have a chance, and that is one of the roles that Nurses for Newborns plays, is to reduce that kind of barrier of transportation, of access. We also don't charge families anything for any service. We don't even have a mechanism for it. So, and getting families to understand that they can advocate for themselves is the second thing. And helping families learn advocacy skills that they may not have picked up over the years or never had anybody sit down and talk with them. How do you advocate for yourself? No, this isn't right. I have a headache that won't stop. What should I do? And rather than hanging up the phone and crying, which is what happened with the mom I told you about earlier. So our nurses and community health workers teach those advocacy skills to families. They use real-time things that are happening in their lives to support, coach, walk alongside, and empower the moms, dads, family caregivers. Sometimes it's a brother or sister who learns what to do when there is a systems issue and how to resolve it. The other thing that we're doing at Nurses for Newborns, and I have one of our board members here, so, is that our board of directors voted this past summer on a new strategic plan, and we realized that we have an opportunity to add value into the world of mom's health. We're known for infant health, that's our name, Nurses for Newborns, and our referrals largely come historically from babies who are already on the earth. But we actually do have an opportunity to not only just talk more about maternal health, but also to make sure that we're leveraging our visits with families around mom's health as well. And so we've been doing it from day one, but we are now emphasizing that in the next couple of years, making sure our staff have the training that they need to watch for signs and symptoms and do the broad kind of teaching that we need to do with moms around their own health. So that's something that all of the nonprofit family-serving organizations can take a look at their own work and say, what do we have the capacity to do and what can we add to it? What are the next pieces? And the other piece that we have added over the course of the last 10 years is to add community health workers to our workforce. And community health workers serve in our organization as peer mentors. And they are women with lived experience. They live in the communities where they work. And they work side by side with the nurses and sometimes in their own practice with families and have a different kind of viewpoint and worldview than maybe our professional nurses do. And when you add them two together, it's a very, very strong and impactful way to surround families with that kind of experience and love. The other thing is that we are highly collaborative and have been from day one, but really over the last decade have accelerated that. And we can't provide everything that a family needs. No organization really can, but we sure can join arms, link arms with other organizations. There's a really good example of this that Terry sort of started the story on, which is Missouri Foundation for Health. Funded Flourish and supported the Flourish project. We were involved in the early days of Flourish. I ended up chairing the action group on infant health. And in that action group on infant health, we studied the data on what factors are really showing up as disparities in infant health. And one of the things that rose higher than any one of us expected was safe sleep. And are babies going down to sleep safely? Yeah. Or are they not? And we learned from the community data that infants of color, Black infants in particular, are 4 times more likely to lose their lives before their first birthday than white infants by being in an unsafe sleep position, strangling during sleep. And this is preventable, folks. This is something that we can step up and do something about. And so with the foundation's support, and then it's a long story, but we had a group of providers that started meeting specifically around this issue. We applied for some statewide funding for a project that was happening statewide, and we now have the Safe Sleep First project in the St. Louis region. We're covering 9 counties, including St. Louis City and County, the surrounding counties, and there are now 18 organizations who have signed into it. And who meet every other month to problem solve, to coordinate, to make sure that every baby in our community has a safe place to lay down and that they're not in unsafe equipment or co-sleeping in a bed with covers and things that we know can lead to suffocation, strangulation of an infant. And so we are working together. There's a very similar example around behavioral and mental health services for women, that organizations are coordinating, collaborating, sharing information, and this is the way we're going to get work done, is all of us rowing in the same direction with our individual expertises, but using that collaborative spirit to make sure that we don't have families falling through the cracks. So, what can you do? Well, first of all, any support that you can provide with volunteer service, funding, interest even in the service providing organizations that serve this age group and focus on this work is going to make a difference. Trust me, it does. Even the smallest, what you think is the smallest of effort or the smallest of support can actually make a big difference for us. The second thing is to fight with all of your heart racism in our community, and we all have to examine our implicit bias and work toward anti-bias, anti-racism in our own work. And then the last thing is to advocate for supportive legislation. You can do that as a citizen, as a voter. There are a couple of issues on the docket right now, including we have been trying for 12 years, I'm looking at Mary Elizabeth. We have been trying for 12 plus years to get Medicaid to extend coverage for women until at least the baby's first birthday. Right now, if you're not aware of this, a woman who is on Medicaid, we actually have quite a few resources to have a pregnant woman get Medicaid services if they don't have health insurance. And then when the baby's 60 days old, it ends abruptly. And so when you have missed your 6-week follow-up appointment because transportation didn't show up, then the health issues that roll down from just that problem are immense. Our nurses see it every day. You know, having a family tell them, I have bronchitis, I know that, I can't go to a doctor, I don't have the money, and then waiting, maybe all day in a clinic to be seen, it just adds to honestly, the humiliation of being in that situation and not having the resources to take care of themselves. So we're really close. We got really close last year. We're so close. So that would make a huge difference, is that one bit of legislation. There are other issues around legislation that you can watch for, but you can help us with that. So with that, I'm going to turn it over to DiAnne.
Thank you. Yeah, there's a lot going on, isn't there? Oh my goodness. When I think about creative ways to address this issue, again, I reflect on the importance of listening, that we can't, we were called experts earlier today, and that I always kind of shake when I hear that, because the experts really are the moms that are living this, the families that are living in this situation, and that's where we get our advice for. So it was 26 years ago, actually, that I started a parent advisory board for the Crisis Nursery, 26 years ago. And so every month for 26 years, I've had the good fortune to meet with women that have graduated from our programs, to listen to them. My staff jokes that it's the one meeting where I'm the most quiet. I don't talk much in those meetings, because I want to hear from these young women that live in challenging communities, that are doing the best that they can do. And these are women that have graduated from our program, but life is still really, really hard for them. And they are amazing, absolutely wonderful. We had our big gala, we have to raise 94% of our funds ourselves. And we get a little money from the state, that's about 6%. But at our big gala a couple of weeks ago, we had they're all my favorites. These young women on this board are all my favorites, but this one in particular, Davida, it's her name, and her husband Jamel came, and they told their story of what it was like, what life has been like for them, and how hard it's been. And how brave is that, to stand in front of 500 people and lay it all out there. But this is a young woman that I've learned so much from over the years, and she has helped us grow and expand our program. And her story, of course, starts with a crisis and being alone and needing help. The nursery intervening and her working really, really, really hard. And then Jamel coming on the scene and working really, really hard and being just a great dad. And the story ends with him being a union electrician now, and her working for another nonprofit, and they are buying a home. And for the first time in either of their extended families, they are buying a home. Life has changed. And I have hundreds of those stories. And so for me, it starts with listening, learning is the next part, because if I just listened and I didn't learn it, that wouldn't help, and then take an action. And the action that we've been taking is to be in the communities that need our help the most. And so my bio hasn't been updated, because it said we had 9 family empowerment centers. We have 11. And this summer we'll open number 12. And each one of those is in a strategic community. And the first one that we opened was in North St. Louis City at St. Teresa's and Bridget's. The second one that we opened, and is still open today, is East St. Louis. East St. Louis at the Christian Activity Center. And the reason that we do that is that we don't want families to have to travel, or transportation is awful. Have you ridden the bus systems lately around here? It's awful. It's just awful. And we expect families to get to these appointments, and they're late, and then you sit around a clinical table and somebody might say that they're not cooperative, they're not motivated. That's a red flag for me, and I don't tolerate that, and I know none of you would either. And so that's why we are in all of these different communities. We've been in Ferguson now for the last 8 years. They invited us over there. And so being where the families are, and partly why I mention that is because when you live in their neighborhood, they trust us. We have their trust. And when we have their trust, if they start to not feel well, or if they don't think they can care for their kids, they're gonna tell somebody. And oftentimes it's one of our family empowerment workers, one of our staff, so that we can help them before things get worse, right? We don't want things to get worse. Because in our state, do you know what happens when things get worse? The Children's Division gets involved. And do you know what happens when the Children's Division gets involved? And especially if you are a person of color, it is very possible that they will take your children away. 14,000 children today don't live with their families. They're in foster care. 14,000. And did you know that 45% of those kids will never go home? Never go home. It was on the front page of the Post-Dispatch very recently, and in the Missouri Independent, if you follow that online. 45%. And that could be an infant. That could be a toddler. Those are our kids that we have to take care of. Those are our children that need us, and that we need to be listening to the families, and we need to be helping them in whatever way that we can, and helping them be successful. And that's why we do parenting groups, bringing parents together that can learn from each other. That's why we do case management. Folks, that's why we pay the rent, is because in our state, if you get evicted, you may end up losing your children. If your utilities are turned off, if the little ones come home from school and the utilities are turned off, and the food spoils and there's no food, if you get hotlined, it's possible those children will be removed and they may not go back home. So that's another thing that we're just really tuned into, just really wanting to be in the communities and paying utilities, paying rent, showing up with food, showing up with formula, just helping families and building their trust so that when they have concerns, when there are things that they're worried about, they can't take care of their infant. We don't want them to take the baby to the local fire department and leave the baby there. That is a program that you can do. We want them to come to the crisis nursery. And we have that happening occasionally. It's not a lot, but especially with our young moms, we have some 16, 17-year-old moms that don't think they can be parents, don't have the support, don't have the tools to be able to do that. But when they find out that there is such a thing as a crisis nursery, and that we have cribs for them, we have formula, we have little snuggly outfits that they can wear, we have everything that they could possibly need, and we will help them be that parent, and they don't have to give their child up. So those are some of the things that we're doing. As you can see from the little handout that we put together for you today, 30,000 hours of care we provided to families that have infants just in the last year. 30,000 hours of care. We had 750 families call us that needed help, and that's oftentimes it's in the middle of the night or it's on the weekend, so that's so important to be available. And almost 600 families were involved in our family empowerment, and that's our aftercare program. So, and then when you look on the other side of that 95% of those families met the safety and stability goals that were set for them, reduce their stress level, young single moms reduce their stress level, and increase their protective factors. So we have a lot of research that we're doing at the Crisis Nursery. We track everything. Every family is followed, every number, every statistic that we have. And what I will end with is, we in St. Louis have a lot to be proud of. Our model is being duplicated all over the country. We are working with a group out of Texas right now that wants to know what the magic is. How do you get 100% of these kids not abused or neglected? How is that possible? And so we are being able to have an impact for children all around the country, and especially moms and infants. So thank you.
Yeah, so mostly what I have is to reiterate and reinforce what's been said here and the importance, I mean, you all being here, listening, learning, caring about these issues, educating yourself so that we can turn that into advocacy, whether it's around the Medicaid expansion of postpartum, there's a tax bill right now around removing the luxury tax from period products to increase, which we would hope will increase access and affordability for individuals. Knowing that these things are going on, being involved, communicating those, and then and talking to people so that it's not just a few people or organizations, but that it's part of kind of the community calling. And then speaking about the collaboration, you know, how important the collaborations are across organizations, and us as a university, you know, having that responsibility to educate and to train. So we have a Master's of Public Health degree program, and fortunately, many of your organizations, all of our students have to do practicum in internships, right? They have to learn. It's one thing to talk about these things in a classroom, to have discussions, even to bring in guest speakers. It's a whole nother thing for the students to be working directly with communities, with schools, with organizations, getting that hands-on experience. So we are very appreciative of the collaborations and those opportunities for the students, because they really are developing into the young professionals who are going to be carrying this work forward. And all three of your organizations, I know, serve students at different times, and so that is something that is part of kind of building the network and building the set of resources so that we can address these issues.
Well, I want to thank you all for coming and being with us today. Kate's going to get out all the resources that were mentioned. Cheryl, I really appreciate the work that you're doing in your parish with that group of women, because to me it's about circles, it's about women being together. Charlie, your work too, I want to call that out. Thank you very, very much. My daughter had a doula, and it makes a big difference. So thank you so much for being there for those young women. And have a beautiful day.